close till I get up. Time is barely on our side. I don't wanna waste what's left.
Hello and a very warm welcome to this mega chapter of tuberculosis and National TB Elimination Program. We all know that TB is a big public health problem. Why? Because TB changes a lot, because there is so much resistance. Therefore, because there is TB changing, there is program changes, and because there is program changes, a lot of MCQs are attracted from tuberculosis. In case you are UG student beta, these are the following competencies that are the objectives of this whole 3 video modules that we have made for structured for tuberculosis understanding and the National TB Elimination Program. In this 3 series, we need to talk about the epidemiology, the predisposing factors for TB resistance, which makes it a public health problem, and the TB program, the ATT regimes, chemoprophylaxis, and health education for the healthcare workers. So in this video module, we are going to talk about basics of TB epidemiology and the diagnostic modalities which are available. First point for us to understand is that it is always said that TB anywhere means TB everywhere. Why? Why is it said that TB anywhere is TB everywhere? Why? Because it was because of a very important understanding that it has very high infectivity potential. Do you know that one case of TB, one case of tuberculosis, if that one case of TB is left untreated, if you don't treat it, how many new cases will happen? Can you believe that untreated one case of TB can cause 10 to 15 new cases of TB per year? Within 1 year, if there were 10 cases, you will get 100 to 150 new cases. That is the potential, and that's why we say that TB anywhere means TB everywhere. Beta, second point. First MCQ was regarding the infectivity potential. The second point is, what is the theme for the National TB Elimination Program that we have for this year 2022? The theme that we have is Invest in Tuberculosis to Save Life. So before we go ahead and talk about some other more important epidemiological determinants, I would just like to appraise you that whatever we are going to discuss in these 3 video modules, we are going to discuss from the India TB Report 2022, which was released on the World TB Day, that is on 24th of March. Every year we observe World TB Day. So the slogan of this whole National TB Elimination Program is TB Harega and Desh Jeetega. So that is what is the slogan. There is a new slogan for tuberculosis this year, that is TB Mukt Bharat. TB Mukt Bharat. We already had Anemia Mukt Bharat, right? So let us have maybe an overview about the statistics from tuberculosis. If you talk about the TB notification rate, please note that in year 2019, the TB notification was some X number, okay? It was around 22-23 lakh. Then in 2020, we saw a dip in the cases. Why? Because there was COVID-19 pandemic, right? So 2022, we had decrease in the cases, probably because the reporting, the notification was not so much, because the people could not come to the health facilities or so many problems happened, lockdown. And then in 2021, we again saw an increase in the number of cases. Today, like last year, in 2021, we were reporting 19.5 lakh tuberculosis notifications happened in 1 year, in year 2021. Another new number that you would like to remember for your exam is the incidence of TB. The incidence of TB that has been updated, it is slightly higher. That is what is the point of worry right now. It is 188 cases. 188 cases were reported per lakh population in India. So that is kind of a higher incidence. The MDR cases have definitely decreased. They were 4 per lakh. The XDR is 1 per lakh. The case fatality rate could be as low as 3% in normal tuberculosis. Drug-sensitive tuberculosis could be as high as 20% in the XDR cases. If you talk about the cause-specific death rate, that is 37 per lakh, that has been almost standard over last few years. That is about some of the TB statistics you would like to remember. These are the updated numbers. The agent factors we are going to talk about tuberculosis is, what is the agent? It is a Mycobacterium tuberculosis. Mycobacterium tuberculosis, this is a strict aerobic bacilli and is facultative intracellular bacilli. This bacilli, on the outer wall, it has mycolic acid, and because it has mycolic acid, it stains with the acid-fast stain. What is the acid-fast stain? That is ZIEHL, ZIL. Ziehl-Neelsen stain. So it stains with a Zn staining, and this is Mycobacterium tuberculosis. Question number 2. This is acid-fast bacteria. Do you know any other acid-fast bacteria, other AFB stain, other AFB bacilli, acid-fast bacilli? Yes, other acid-fast bacilli could be there, like Nocardia. We can also talk about Isospora. We can also have Mycobacterium leprae, which are the other leprae, which is the other acid-fast bacilli. Question number 3. This is caused by tuberculosis disease is caused by Mycobacterium tuberculosis. Who discovered Mycobacterium tuberculosis? I think everybody knows that was Dr. Robert Koch. Dr. Robert Koch discovered TB bacilli on 24th of March 1882. I don't want you to remember this date, but unknowingly you will actually remember it. Why? Because 24th of March every year is also celebrated as the World TB Day. And the theme for the World TB Day is to invest to end tuberculosis and save lives. So that was question number 3. Question number 4 is that all we were talking is about the typical bacteria, typical bacilli, AFB bacilli. So what are the atypical bacilli? Atypical mycobacteria. The atypical mycobacteria could be the photochromogens, scotochromogens, or the non-photochromogens. Photochromogens, how I have remembered is that when we were small, we used to take photograph by Kodak camera. So just remember, Kodak camera was Mycobacterium kansasi. Then we have S for scotochromogens, S for scrofulaceum. And then we have non-photochromogens, that is the Mycobacterium fortuitum. So these are some of the questions which may be asked about the agent factors. Coming over down to the host factors. Topic number 2 is about the host factors. Host factors, what is the peak age for having tuberculosis? Of course, it is common sense. It is in the middle age group, 15 to 45 years of age group is the peak age, probably because at that time people are mixing a lot. Another host factors, it is also related to nutrition. Malnutrition or undernutrition is a very big risk factor for causing tuberculosis. Based on this, about the agent factors and the host factors, now you will be able to understand the topic number 3, that is the environmental factors. Instead, in tuberculosis, instead of environmental factors, we usually talk about the social factors. So it means this technically the same. In social factors, we are talking about like poverty is a big time social factor for having as a risk factor for having tuberculosis. Alongside it is malnutrition, which we already talked. Alongside it is overcrowding and unhygienic conditions of living, low socioeconomic status. All these are the environmental factors for having tuberculosis. Next in line, big topic number 2 is about pathophysiology. So that was about the epidemiological determinants, agent factors, host factors, and environmental factors. Next in line is a little bit about the pathophysiology. So if we just look at the lungs, in the lungs, at the first stage, the TB bacilli is going to attack what part of the lung? It is usually the hilar area. It is usually the hilar area in which the TB bacilli is going to stay. And this first lesion that happens is the Gons focus. It is the Gons focus. Along with the Gons focus, if there is involvement of the lymph node also, what is this called? Gons focus plus the lymph node. It is called as a Gons complex. This Gons complex may calcify and forms a Rankes complex. So a lot of things can happen at the first level. This understanding, this having TB for the first time, this is what is the primary TB infection. Now, what can happen in case of this primary TB infection? What can happen is that in 95% of cases, the TB bacilli is being healed by the body. So this is called as a healed tuberculosis. On the other hand, if you just look at the other side of the story, the TB bacilli may cause a local inflammatory reaction. So that is a local inflammatory reaction. This category. This category is called as a progressive primary tuberculosis. This is a progressive primary tuberculosis. Why do we say progressive primary? Why? Because it is the primary focus, it is the main focus which is actually progressing over there as a local disease, and this is what we call as the PP, progressive primary tuberculosis. It is usually seen in children or in people with low immunity. It may cause a local reactions. So the patient might present with features like fever. There may be a chronic cough. There could also be pleuritis. There could also be a pneumonia, pneumonia-like picture, pneumonia-like illness. And the patient might also present with some of the hypersensitivity reactions like the erythema nodosum or the flictanular conjunctivitis. So there are two things you have understood over here. Either a person could be a healed tuberculosis, or the person could actually show a progressive primary pulmonary tuberculosis. Now there is a third problem which actually happens. The third problem, which in reality is a big headache for us, is that some patients, either we have been working in tuberculosis ward all the time. So either a person would be having a healed TB, which of course most of us, God willing, would have had. Some of the patients might actually land up into a progressive tuberculosis. Progressive tuberculosis is very less. It is less than 1 to 2% of the total primary TB cases. Healed TB is there in 95. So now the problem is with this center, either you show TB or you don't show TB. Now these are the people which are hanging around. They neither show TB, they don't show also. So this TB, the TB is lying in a good night mode. So the TB is what we call it as a latent TB. So now this TB becomes dormant. Now this TB bacilli is stuck over to the parts of the lung and it doesn't cause disease, it doesn't heal itself. This is called as a latent TB. Now if you look at this latent TB now, what will happen to the latent TB? In latent TB, sometime the patient might have very low immune status, or there might be some stress, marriage problem, financial problem, friend problem, girl, boyfriend, some problem will be there. There will be some stressor. That's what I want to say. There will be some stressor. Now what happens is, now this TB bacilli, under the effect of the stressor, now this TB bacilli will wake up its eyes. Now this gets reactivated. Listen to the words. This gets reactivated and it causes what? It causes cavitation. It causes cavitation. My small question to you is, why do I draw like this, that the TB bacilli and it causes cavitation only in the apex? Do you remember from physiology, you must have done that if this is the lungs, where is the maximum ventilation? Ventilation is highest where? In the upper part, middle part, or lower part? Where do you want to say? In the upper, middle, or lower? Ventilation is highest where? Ventilation is highest where? In the upper part, ventilation. And perfusion is highest where? Perfusion is maximum in the lowest part. In fact, perfusion is lowest in the top part. And that is why we say, you must have heard it in physiology, that V over Q ratios, V by Q ratios, they are maximum where? They are maximum in the upper part. So now this TB bacilli beta has to make a cavitation. It will have to make what? It will have to make a cavitation. What is cavitation? It is a delayed type 4 hypersensitivity reaction. Now if it is delayed a type 4 hypersensitivity reaction, now you tell me that where will, if anybody was the TB bacilli, where would that TB bacilli going to stay? Will it be in areas with very high perfusion or in areas with very low perfusion? It has to be in areas with very low perfusion with a decent amount of ventilation. Why? Because this is a aerobic thing. So now this TB bacilli is going to stay in the cavitation in the apical area, in the apex of the lung. Now this TB bacilli is a lot of TB bacilli in this cavitation, and through the bronchus it may spread. So now this problem may be there, that if this is there, now this person may spread tuberculosis. And because it spreads a tuberculosis, this TB is called as, now you tell me, this TB is called as a secondary TB or a reactivation tuberculosis. And you are going to treat whom? Are you going to treat the primary TB or the secondary? You are going to treat the secondary TB. So with that understanding, I think you have understood that there is a primary TB infection. That is the first TB infection. That is what we have as the Gons focus, Gons complex. And then you might have a secondary TB infection or a secondary TB reactivation or a secondary TB disease. To have a secondary TB disease, the person must have had a primary TB infection. Do you know that approximately 40% of the Indian population will actually have had a primary TB infection, and 95% of those must have already have been a healed tuberculosis. Very few will land up into latent TB. How many people land up into latent TB? It is usually only 2 to 4%. So 2 to 3% or 2 to 4% will land up into latent TB, which may actually land up. Out of this 2 to 4, less than 1%, 1 to 2% will actually land up into tuberculosis. Remaining 90-95% will not have any problem. So this is what is the basis of pathophysiology, and based on this, I think it will be easy for you to understand the diagnostic modalities and about the National TB Elimination Program, that why we are targeting about the TB infection and about the TB disease separately. So what we have done till now, we have talked about the epidemiological determinants of tuberculosis. We have also talked about some of the basic concepts in pathophysiology of tuberculosis. And next in line, let us talk about the diagnostic tests which are available for the program for diagnosis of tuberculosis. So that is your big topic number 3, diagnostics of tuberculosis. If you talk about all these investigations, you have a lot of investigations. Let me just talk a very simple and a very basic investigation first, that what is a chest X-ray. In chest X-ray, you are going to find the cavitations. That is what you are going to do. And because finding the cavitation could be based on the quality of the chest X-ray, it could be based on the quality of the reader of the chest X-ray. Therefore, we say that chest X-ray is a non-sensitive and a non-specific investigation. It is not actually used for diagnosing of TB in India. Next in line, let us talk about a lot of questions come from the sputum part. So what about the sputum testing? The sputum testing is done in all the microbiology labs. Where do we send that patient for checking of TB sputum? Please note that the sputum testing is done something called as the designated microscopy centers. In designated microscopy centers, we do the sputum testing. This is called as the DMC laboratory. So if there is a patient, you are a doctor working in a nursing home or in a hospital or in a clinic, and you find that a patient may be having tuberculosis, you need to refer that patient to either a tuberculosis unit or a tuberculosis hospital or a DMC. So what do we do in DMC is we collect sputum sample. First MCQ, how many sputum samples do we collect? We collect 2 samples, right? So when do we collect these 2 samples? Is it spot and morning or morning and spot? Please note it is the first sample is always the spot sample, immediate sample, and then we give the patient that sputum container and the patient will get a morning sample also. So the spot sample is always called as the sample A and the morning sample is always called as the sample B. This has been your previously asked question. So it's kind of important for us to remember about the sample A and the sample B. A sample will always be the spot sample. Next in line is that you need sputum for checking. So the sputum sample that is collected, it should be checked within how much time? It should be checked within 24 hours of collection of sputum. It should be checked within 24 hours. How much sputum do we need? So that also amounts to the quality of the sputum. How much sputum do we need? We need minimum 5 ml of sputum should be there. This sputum should be expectorated or it should be from the oral cavity only. Please note it should always be expectorated. Should it be a mucoid or a purulent or anything? Yes, it could be anything. It could be a mucoid sputum, or it could be a purulent, or it could be a mucopurulent. Anything would work. How will you come to know that in reality the sputum is expectorated and not from the oral cavity or not from the saliva, especially talking about the morning sample? We have to ensure it by when we see the test, when we see the slide, if the number of squamous epithelial cells, If they are more than 10%, then that means they are basically from the saliva area, from the oral area. So the squamous epithelial cells should always be less than 10% in a expectorated sputum. It could be mucoid, purulent or a mucopurulent. It is always expectorated. 5 ml of sample to be tested within 24 hours. We have two samples, that is sample A and sample B. These are a lot of questions which come around the quality of the sputum and the turnaround time. What is the turnaround time? That usually the test for sputum should be available within 1 day. Next is, how many types of sputum testing do we have? If we talk about the types of sputum testing, we can have different types of testing, like we can have a conventional microscopy, or we can also have a LED microscope, or we can have still advanced version, that is a fluorescence microscopy. In all these conventional microscopy or the LED or the fluorescence, you're going to test for what? You're going to test for the acid-fast bacilli, right? So the acid-fast bacilli testing can be possible, but which of the following is the best test? The best, we say, is fluorescence microscopy. If this is not available, the next best test is LED, and if this is not available, common sense, the best is conventional. So better than conventional we have is LED microscope, which have a brighter light and easy to identify AFB bacilli, and better than that we have is the fluorescence microscopy. So in fluorescence microscopy, what is the stain we use? We do not use the normal. In conventional microscopy, we use the Zn staining. LED microscope, only the microscope is different, right? So in the fluorescence microscopy, we use a different stain, that is the auramine O stain and the auramine rhodamine stain. Auramine O rhodamine stain is used in fluorescence microscopy, and in the conventional we use a simple Zn, not simple, it is what we use as a Zn staining. If you talk about the AFB grading, you can see over here that there is a bright field magnification, there is a fluorescence magnification which is of two types, 200x and 400x. So leave aside what is 400 and 200, these are the different types of fluorescence microscopy, but this is what is the grading of AFB is done. What normally in most of the DMC labs, DMC is the designated microscopy center, most of the DMC labs that we have in India, we are using a conventional microscopy, and the grading is simple, negative, scanty, 1+, 2+, 3+. When do you say 1+? How I have remembered is 1+. Just look at the screen. 1+ means 10 bacilli, 10 to 100 bacilli in 100 high power field. If there are up to 100 bacilli in 100, so 100 by 100 means what? 1, and 100 by 100. So I've just remembered, if there are up to 100 bacilli, that is 1+. If there are less than 10 bacilli in 100 high power field, less than 10 bacilli in 100 high power fields, that is called as a scanty sample, and more than 100 if you're getting, that will be either 2+ or 3+. When do you say 2+? If there are 1 to 10 AFB bacilli in every high power field on an average. What do you mean by high power field? What is a high power field? One length is equal to 2 centimeter is equal to 100 high power field. So 100 high power field is equal to 2 centimeter of the slide. Okay. So please make sure you understand 100 high power field to 2 centimeters on the slide. That's what you need to remember. So 2+ means 1 to 10 AFB in every high power field, and 3+ means more than 10 AFB on average in every high power field. So it's easy for me to remember if I remember 1 means 100 by 100, 100 bacilli in 100 high power fields. That's what I have remembered. So otherwise, these are the AFB grades for us. So these are some of the MCQs which you can get about sputum testing. Please note that the sputum testing we do in 2 sputum samples separately. Next is another test over here, that is the genotypic test, rapid molecular test that we have is the CBNAT. What do you mean by the CBNAT? CBNAT stands for Cartridge-Based Nucleic Acid Amplification Test, CBNAAT. It will test about what? It will test about nucleic acid amplification test. Please note, if somebody asks you about sputum, which is the most sensitive and the most specific test? Most sensitive and most specific test. So highly sensitive and good specificity also is sputum. But if they ask you about CBNAT, it is highly specific test and it has good sensitivity also. I'm not saying it is less sensitive, but CBNAT has high specificity compared to the sputum. Sputum has higher sensitivity compared to the CBNAT. Are we getting this? So all said and done, they both are sensitive and specific, but sputum has higher sensitivity, CBNAT has higher specificity. Question number 2. This CBNAT is useful for what? CBNAT is a diagnostic test. CBNAT is also a confirmatory test. Why confirmatory? Because it has high specificity, right? Common sense. Question number 3. It will tell you about what? It will tell us whether the Mycobacterium tuberculosis is there or the Mycobacterium tuberculosis is not there. So it very importantly, see, it's a nucleic acid. So if you in a sputum, if you don't find the nucleic acid, that means that patient does not have the nucleic acid. That means the patient does not have the TB bacteria, bacilli. Are we getting it? So nucleic acid amplification test, there's a molecular test. It's a very good test. And it tells you whether, definitely it will tell you whether the TB bacilli is there or not there. Pakka. It has to tell you. There's no way that you'll say that maybe they're not there. So one is this. Second point, what is the biggest advantage of CBNAT? This is what I love. If I was the examiner, I would have definitely asked you on this, that what is the biggest advantage of CBNAT? We were already having sputum, which is a very good test. Sputum has more than 90-95% sensitivity specificity. So why do we go along with CBNAT? CBNAT is such a beautiful test that it can tell you about, with high specificity, it can tell you within 90 minutes. So what is the turnaround time for CBNAT? It is only 1.5 to 2 hours. If you get one discrete answer, please mark 90 minutes. Otherwise, we generally say the test is giving result within 2 hours. Okay. So if you get single best answer, just mark 90 minutes. That is the single best. Another point number 5 is another advantage of the CBNAT is that it tells you, one is the turnaround time. It is only 90 minutes. And that is one big advantage. Another advantage is it also tells you about the rifampicin status of a person. Very important. Rifampicin status of a person. It will tell you whether the rifampicin is resistant or the rifampicin is sensitive. So no test was telling us this before we had launched CBNAT. CBNAT is kind of an expensive test, but all said and done, the advantages of CBNAT is rifampicin sensitivity. It tells you within 2 hours, 90 minutes, and it tells you pakka that the mycobacterium there or not there. That means it is a highly specific test. The best thing about CBNAT is specificity. The best thing about sputum is its sensitivity, and they both are reasonably high sensitive and reasonably high specificity. Next important point over here is that what do you mean by a true NAT? We discussed over here that what do we mean by true NAT. So what is this true NAT? If you talk about the true NAT, that is a Indianized version. It is a Indianized version of the CBNAT. It is less cost and it has been approved. It is now approved by the National TB Elimination Program and it is now launched under the NTEP. So TrueNAT has a very similar results, sensitivity, specificity compared to CBNAT, and the cost is only 1/10 or less than that for TrueNAT. And TrueNAT was produced from Goa and it is Indian version of the CBNAT which is being adopted by the National TB Elimination Program. If you just look at the screen over here, what is this? This is what is the machine for CBNAT. CBNAT, the machine that we have is called as a gene expert, which starts with an X. It does not start with E. This is what is the CBNAT machine. You can see over here very well, I think the cartridge is there. Can you see the cartridge? The cartridge is there. And this is a cartridge-based nucleic acid amplification test used for diagnosis of tuberculosis. So these were some of the molecular tests. Apart from the CBNAT and the TrueNAT, you can also talk about the line probe assay. Line probe assay is also a molecular test. And what is the advantage of line probe assay? Line probe assay, the wonderful thing, the advantage is it tells you return of the report is within 48 to 72 hours, 2 to 3 days. That's such a beautiful thing. Just in my post-PG years, we have seen transition from diagnosing TB in around 4 to 6 weeks we used to take to diagnose TB, and now we are talking of 2 to 3 days of finding the resistance in TB. So it has been a massive jump within the last 10 years for tuberculosis. So the line probe assay, the result is going to reach to us within 2 to 3 days. Line probe assay, it tells you about what? It tells you about the resistance pattern in a TB bacilli. It tells you about the various resistance pattern. It can check about the isoniazid resistance. Please note that isoniazid resistance, that is the H resistance, right? Isoniazid is given by the alphabet H, okay? So I hope everybody knows this. HRZE. H means isoniazid. R means rifampicin. Z means pyrazine amide. E means ethambutol. This is the first line ethambutol. This is the first line drugs that we have in tuberculosis. Please note what I was writing over here is that isoniazid resistance, it is the most common resistance. And we have the resistance checking for INH gene. We can have for the CAT-G gene for isoniazid, ethionamide, the INHA promoter, the fluoroquinolones are checked using the GYRE A and the GYRE B. And for all the second line injectables, that is the kanamycin, amikacin, capromycin, we check for the RRS and the EIS promoter genes. So these are some of the tests which will tell us about the resistance pattern in TB bacilli. The LPA under the program, I will be saying it in two different words. One is called as a FLLPA. FLLPA means the first line probe assay. So what is the drug you are going to check in the first line probe assay? It is the isoniazid resistance, both INHA gene mutation and the CAT-G gene mutation. What is this SLLPA? SLLPA will mean the second line probe assay. What are the drugs we are going to check in second line probe assay? We will check the levofloxacin or any fluoroquinolone resistance. We will check the second line injectable. We will also check for any other second line drugs which are available to us under the program. Another type of the molecular tests we can talk is about the BACTEC method, or we can have the MJIT method, BACTEC method or MJIT method. The thing about the BACTEC is, in the BACTEC, I see a C, okay? I see a C, whereas there is no C in the MJIT method. So what is the use of the BACTEC and the MJIT methods? Primarily, the BACTEC is with a C. It is with a carbon-14 labeled immunoassay. It's a carbon-14 labeled palmitic acid, which is actually immunoassay. So it's a carbon-14 labeled immunoassay. It will tell you about what? It will tell you about the carbon dioxide emission by the bacilli. So carbon dioxide emissions will be told by what? It will be told by some of the bacilli which are actually multiplicating. So it will tell you about the live bacilli. It will tell you about the live bacilli. And MJIT method, there is no C. So because there is no C, how I have remembered is, because in BACTEC, they are going to check for the carbon dioxide levels. In the MJIT method, they are going to check for oxygen consumption. So oxygen consumption methods or the carbon dioxide emission methods, they both can be telling you about the live bacilli, but more specific would be oxygen consumption, because it will actually tell you about the rapidly progressing and the rate of the progression of the bacilli. So this oxygen consumption is going to tell you about the metabolism rate of the bacilli, and it is a very good predictor about how many persisters are there, rapid growers or the fast multipliers are there. And these BACTEC methods and MJIT methods, they are also used for drug sensitivity testing. They are also used in research. They take RESEARCH. They take a little bit extra time, but yes, they are approved under the program, but primarily we use them only as second line investigation. The first line investigation is always sputum, CBNAT, line probe assays. That is the only three things we are going to play around with in the program. But yes, MJIT methods or the BACTEC methods, or these are also the other phenotypic methods, right? So these come under the head of the phenotypic methods because you're talking about the bacilli. So phenotypic methods could be BACTEC or the MJIT, and they are also deployed under the program. Coming over to the next one is the culture methods. What are the culture methods? We can have the egg-based culture or the agar culture, or we can have the liquid culture. The egg-based media, that is the solid media. What is the solid media we use for tuberculosis? Even when you were so small, you knew about the solid media. You have been learning about it since last so many years. That is the Lowenstein Jensen media, which you call it as the LJ media. Your favorite answer is solid media, LJ media. The agar-based media, or we can talk about the liquid culture. Please note that egg-based media, it takes a lot of time, 8 to 10 weeks to come. Agar-based media is also not used in India under the NTEP. What we use is the liquid culture. Liquid culture using the BACTEC methods or the MJIT using the MJIT methods, or we use the liquid culture. In this liquid culture, it could be the Kirchner media, or we can use the Middlebrook media. And the results would technically come within few days, like 1 or 2 weeks. It takes time for liquid culture to come, and these are deployed in the program under the NTEP. We are using the liquid culture methods. Coming next is point number 6, that is the serological test. Please note that serological test would tell you about the antigen antibody test. The other serological test is also called as the IGRA test, or we can have the quantiferon gold test, platinum test, different test. Please note that IGRA test has been used in some countries. IGRA stands for the immune gamma release assay. Immune gamma release assay. Now this IGRA test will tell you what? What do you think? This IGRA test will tell you what? The IGRA test will tell you about the primary TB or the secondary TB. What do you want to say? Common sense, IGRA is immune gamma release assay. It's a immunological, it's a serological test. It will tell you about the presence of the TB bacilli. So it could be primary TB infection. It could also be a secondary TB infection. How are you going to differentiate that? I already told you 40% of the people will have primary TB. So IGRA test is not used for diagnosis of TB in India. Please note, IGRA test is not used. It is not used. You can write it in bold letters. It is not used for diagnosis of tuberculosis. Diagnosis of tuberculosis anywhere in the world. But yes, for suspicion of tuberculosis, some of the developed countries, like if you go to US, UK, Canada, and these big hi-fi countries, if you go to these countries now, these people, in case they have a suspicion of you getting a TB, they are going to do at the first place, check you for the latent TB. Latent TB, the test of choice for IGRA is done for latent TB. For latent TB, they will do IGRA test. Otherwise, there is no utility. In India, we don't use IGRA test. Talking about the antigen antibody or the quantiferon test, please note that these two tests, antigen antibody or the quantiferon, they absolutely are going to tell you what? They will definitely, antigen antibody is definitely going to tell you about the primary TB, right? So if antigen antibody is going to tell you about primary TB, we can't afford that we use these tests in India because there is private system, public system. We can't afford to have 40% as TB infected in India, right? So please note that the NTEP modules, the Ministry of Health and Family Welfare, Government of India, they write it in bold letters that the quantiferon test, the antigen antibody test, these are banned in India. Banned in India. They are not used. Why? Because they will tell us about the TB infection, not at all about the TB disease. And we already know that so many people are infected. Coming to point number 7, a lot of MCQs come on the tuberculin skin test. Many times we do that TST test, right? Tuberculin skin test. So in beta tuberculin skin test, we use 1 international units of a purified protein derivative RT23 with the twin 80. That's such a long name of this simple small thing. Purified protein derivative RT23 with the twin 80. What does PPD stand for? Purified protein derivative. Purified protein derivative RT23 with twin 80, 1 international unit. This tuberculin skin test is also known as, a Piquet test. Pirquet test or the tuberculin sensitivity test, also called as the Montauk test. We don't say Montauk's test, it is called as a Montauk test or a Montauk test, and it uses the PPD23 RT23 between 80. So this tuberculin sensitive test, it is not used for diagnosis in adults. It has some value of diagnosis in children. So it is used under the program, but it is not used for diagnosis of tuberculosis in adults. It may have some utility in children. In pediatric TB, we can use the TST test to be sure that the child is having tuberculosis. So that is just the only utility. In how much time are you going to read the tuberculin sensitivity? It's a sensitivity reaction, right? So you inject the tuberculin PPD23, and after some hours you will see the wheal or the flare reaction. So it is read minimum after 48 hours. But within 96 hours, the average time, if they ask you, you can read it at 72 hours is the ideal time or the average time, not less than 48 hours, not more than 96 hours. So once you are reading PPD23, that is the tuberculin sensitive test, if we all are not at risk, if there is no risk, then if in a person there is no risk, if the PPD23 is more than 15 mm, if the wheal reaction is more than 15 mm, only then we say it is positive. In cases of high-risk children, like people who are some contacts, some high-risk groups, they are from the high-risk groups, or they are from high-risk occupation like healthcare workers, doctors, people working in care home, prisons, recent immigrants, IV drug abusers, age of child less than 4 years. In those cases, in high-risk cases, in these people, we should keep the criteria as lower. The tuberculin sensitivity test, even more than 10 mm should be taken as positive. And in people who are known with HIV, who are known cases of HIV or known with immunos, they are not even high risk, they are pakka. They have high risk. They are in the very high risk groups. So severe immune suppression, close contacts of tuberculosis, history of prior TB. In these cases, even if the tuberculin test is more than, the reaction is more than 5 mm, that should be taken as a positive tuberculin sensitivity test. Next is, what do you mean by a two-step TST? There might be some people who are getting TST test done again and again. So on repeated measurements, on repeated TST testing, the sensitivity of this test actually decreases and the reaction will not happen because it's a hypersensitivity reaction. There is tolerance development. So now there is tolerance and there is no response to the TST. So what we do is that in two-step TST, you do one-time TST. TST is done, and this could be a positive or a negative. In case it is negative, you do a repeat TST. That's the only thing. So in people who get already TST again and again, you give a TST and then you wait for 3 weeks. You do a repeat TST after 3 weeks. And then you see whether it is positive or negative. If it is positive, that means it is a TST positive report. So in two-step TST, you will do 2 times TST with a gap of how much time? With a gap of 3 weeks. That's all that you need to know about the two-step TST. So these were all of your investigations that we were supposed to discuss for diagnosis of TB. Now, before I leave, in this video module, I would like to tell you that which are the diagnostic tests which are actually used in tuberculosis program. So under NTEP, we are using sputum for AFB, and we are using chest X-ray for adults. We are also using the CB-NAT. We are also using the TrueNAT, that is from the Molbeo Diagnostics from Goa. We are also using the line probe assay. We already had talked about the first line and the second line probe assays which are used. First line is for isoniazid resistance. Second line is for all the fluoroquinolone and all that second line injectable resistance. And then we were also using the DST phenotypic test, that is the MJET method or the BACTEC method, or we can also use the liquid culture. But these are only liquid culture. Please note, liquid culture is only for gold standard. It is a gold standard investigation to be taken only in case we cannot prove tuberculosis using CB-NATs, or there is some problem with sputum, or we could not identify acid-fast bacilli. So liquid culture is only taken as the gold standard. One thing more before we close off this session is a frequently asked question. This is a 3 by 5 star MCQ topic about the turnaround time. Please note that if the question says about the solid culture, Huh? Solid culture is what? It is the launched in LJ Media. The solid culture report is going to come within 3 weeks in case it is sputum sample. That means within 1 month. But it also takes 2 months to come in case it is sputum negative. So that is the reason we don't actually use the solid culture, because it takes 2 months. Now in case of liquid culture, we talked about the liquid culture, automated liquid culture using Bactec MJIT 960 TB system. So in those cases, you can get the report within 8 to 10 days in case it is a sputum positive, and within 2 to 6 weeks. So within 1 month, we are going to get the liquid culture report. So usually the liquid culture report would definitely come within 1 to 2 weeks for a sputum positive sample. We can also use some molecular testing like the CBNAT. I told you it is within 90 minutes. TrueNat is going to tell you within 1 hour only. TrueNat is from that Goa. Mall Biodiagnostics is the Indian version of the CBNAT, which is lower cost. And line probe assay is going to give you result within 2 to 3 days. Rapid identification test using the immunochromatographic test is done, but it is not approved under the program. The turnaround time is 15 minutes, but it is not actually done for diagnosis of tuberculosis in India. So with that, thank you so much for watching this module. In the next one, we are excited to present to you the National TB Elimination Program of India.